So basically today I'm going to share with you a new concept of doing angioplasties with either no contrast or low contrast or very low contrast. And that actually uses different technologies like OCT, IVUS and IFR for these procedures. So the objective will be to discuss these possibilities. How do we approach these patients? Who are these patients who need this? And basically, how do we use these technologies like IVUS physiology, which is FFR, and also OCT imaging. So normally, up till now, we have been doing angioplasties based on angiographic pictures like this. And this is an angiographic image. Certainly, we'll need one angiographic image as an angiographic evaluation. But after that, once the visualization is complete in these patients, fundamentally, we do not link our angioplasty to angiography. And then we all do it through the guidance of these imaging tools without contrast administration. And basically, this basically helps us in treating very complex patients, high-risk patients, and the liberal use of contrast medium, which we used to do in angioplasty, is completely minimized. And in these situations, we do not do any intracoronary injections to find out at every step. So these long procedures also who are needing too much contrast, so we can basically do them without these angiographic imaging. And so this is also known as ULC PCI, and certainly people may think that the precision of PCI will be low, but basically in this the precision is complete, and we are able to see complications. We are able to see the outcomes once we have done the imaging through IVUS catheter and additional guide wires, and using the the markers, radiopaque markers of these equipments at every stage. So those people who do not perform IVUS or who do not perform OCT or physiology, then it becomes difficult. So one has to, every interventional cardiologist who wants to perform ULC PCI has to become conversant and has to start using these imaging technologies for doing this kind of a state-of-the-art PCI. And basically, the focus is then placed on how to use them optimally. So who are those patients? Basically, those patients who have chronic kidney disease, acute kidney injury during acute MI, cardiogenic shock. Then sometimes patients have bad coronary dissections and don't want to inject too much contrast. Then spontaneous coronary dissections, CTOs, where we are doing ADR or CAR technique, and of course complex long PCI procedures. Also, it is very helpful to use low contrast PCI, because one of the complications of angioplasty is acute kidney injury, and this is what we are trying to avoid. And in chronic kidney diseases, like you see here in this patient, there is always these patients are complex patients, just to show that they have more calcification, they have more complex disease, and to give less contrast. And that's why many times we were trying to avoid doing interventions in these patients. And they are, and of course, these patients were then either left alone or would go to surgery with certainly higher risks of having renal failure. So there we can use this method, and just to show you that contrast-induced nephropathy is a reality, and we see that with increasing use of contrast. As you start increasing the use of contrast volume, the AKI rate or the acute kidney injury rate goes up. And this leads to poor outcomes in patients where you do interventions. And of course, there is no alternative as yet to the contrast, and there is no other drug which we can use in place of contrast to visualize the arteries. So that is why we have to risk either dilute this same contrast sometimes to see that, or one of the formulas which I also use almost on a daily basis is that if a patient has how much GFR, so if the GFR of the patient is 30, then my maximum limit is 30, no more than that, because that is one of the kind of advices which we take and give to those patients where the kidney insufficiency is there. and we reduce the contrast intake in these patients. And the GFR calculation is very, very important. That's why. And in patients with cardiogenic shock, again, these patients, when they undergo intervention, again, they also develop this complication of kidney injury because of the hypoperfusion during the instability of hemodynamic. And then in those patients also, reducing the contrast material is very, very much recommended. And that is why we use more imaging in those patients than less imaging. And earlier, our habit used to be that do not use imaging, just try to do the procedure with contrast, and that led to more damage to the the whole hemodynamics, to the kidneys, and so on and so forth. Then in patients, as I was telling you about coronary dissections, in those patients where there is a false lumen, if you keep injecting too much contrast, you extend the dissections, and that leads to worsening of the scenario and accelerates the vessel occlusion. So that is why in these patients, using low contrast is always a good idea. In CTO patients, in patients with ADR, again, we rely on IVUS imaging in these kind of patients. And then, of course, in complex long interventions where you are spending too much time, do not spend too much time. So that does not mean that if you are doing a long procedure, you spend 500 ml of contrast. So your procedure is successful, but the patient will not have good outcomes. So this kind of a situation, and how do we do that? Also in imaging and in physiology, we have, this is co-registration of IFFR, and you can see here, as you can see that this is IFR co-registration, which we do routinely to find out which lesion to treat, which lesion to leave, for how long the stent has to be. Everything can be decided by this IFR co-registration. There is no need to keep injecting dye in these kind of patients. And that is why these challenges of, the routine PCI are kind of obviated by adoption of ULC PCI. So, as you already understand that the challenges of ULC PCI for the operator is that he has to engage the guiding catheter, know when the guiding catheter is engaged, because our habit is to engage the guiding catheter and give contrast. We don't do that anymore. We now understand how do we do it, then navigate the guide wires through vessels without putting contrast in that, identification and location of target lesion by the help of IVUS and FFR, ensuring performed balloon dilated stent deployment at target location, again by the help of imaging in FFR. For all these steps, there is no contrast used. And assessing also, final also stenting, assessment of stenting and looking for complications and managing them is all assisted by the help of imaging and physiology. So the final results, so sometimes as I'm telling you that in only when we have used only 3 to 5 ml of contrast in a full angioplasty, where 2 or 3 stents were used, was to just document the final outcome. That's all. Otherwise, sometimes we don't even do that. So basically, what you require is a little bit of skills, which you already have, but you have to just make the mindset change, use of IVUS, use of IFR, and also use of OCT sometimes with the use of saline. So in OCT, we don't use contrast, we use saline with a 50 ml syringe, and it really works very well. So at all stages, as you can see, we can just do that without using any contrast. And then these are the various things you can learn about if your guide catheter is engaged in RC, and if you inject saline, there is a T-wave inversion. You know where the guiding catheter is. It is already engaged. Looking at the pressure waveforms, you will know what exactly is happening. So basically, we do that, very, carefully. And sometimes if you have to inject contrast for a distal wire location, we use 50% diluted contrast. And with a higher frame rate, you can see the vessel better with less contrast. Then navigation of guide wires, again, we do with the help of stored angiography. So if there is an angiogram which was done earlier, you use the same images. So we keep looking at the same images, and on the real-time fluoroscopy, we can match it as to where the wire is going. And then identifying the target flow limiting stenosis by doing a pullback IFR is also very helpful. As you can see in this patient, we can find out where the jump is happening. and then using the additional guide wires and also the additional markers like calcification, etc., can be used to correlate with the site of stenting or the positioning of the stents. So we use this eagle eye IVUS in ULC PCI very commonly. Record positions of the various balloon, or also record the position of IVUS catheter, because it has markers. As you can see here, there is a marker 1, 2, 3, and 4. So these are 10 millimeter distance markers which can tell us how long the stent has to be, or how long the dilatation has to happen, and then comparing it with the IVUS images makes the decision very simple. So it's just kind of training yourself to do that. And here you can see the very complex case like this angulated lesion. We are comparing with the previous images and trying to do with the help of IVUS. So that is quite possible. Using stent boost also is a helpful thing. During the stenting, we can check whether the stent is expanded or not, whether the second stent is overlapping properly or not. All this can be done without any contrast injection. And then complication management is also very easy. We can check, and at the end, if you really want, you can do a diluted contrast injection to check whether there is any slow flow, etc., or not. So these are some two cases which I am going to share with you. And this is a patient where there was an initial angiogram which was done, showed RCA which is non-critical, and LED showed tight stenosis here, and at the distal end there was a thrombus which we detected by the help of doing and this patient had a creatinine of 1.4 or something, and we didn't want to increase any contrast injections, so we did that with the help of first the balloon dilator here, then doing a laser followed by OCT using a saline contrast, and then followed by cutting balloon at the proximal end, and all this was done through imaging, and then followed by drug eluting. So no stent, drug eluting balloons, laser, and cutting balloon, and this angioplasty is done. And in the end, I think we took one shot, and that's all. So this is the only shot we take, just 3 ml contrast, and rest everything is done through imaging. So this is kind of treatment which we can offer to our patients and do not want to give any injury to the kidneys. So this is pre-laser, post-laser, and then the final IVUS. So many times we don't even take the final contrast injection, especially if we are doing a no contrast PDCA. And this is a patient where no contrast was given. Right artery was very bad disease. Patient was rejected from surgery, had also severe MR, for which we did a mitra clip, which is also a non-contrast procedure. And here you can see we are using the these landmarks like calcification, the side wire, to know where we have to dilate this vessel, and no injection is being given, just the dilatations based on the IVUS. And this is, you can see the IVUS catheter telling us how long the treatment has to be, then checking the final results on the IVUS, and then doing this kissing inflation. This is a double balloon bifurcation technique which is being done in this patient, and you will realize that all this is done through the and this is the final injection. Only one injection, 3 ml injection, and everything is done. So what ULC PCI means is that it is a low, ultra low contrast, or a low contrast, or no contrast, and you need IVUS, FFR, OCT. And for those patients who have kidney injury, acute or chronic cardiogenic shock, ADR, all these patients can now be effectively treated by using minimal contrast. So thank you very much.